Parents will often rush into the emergency department describing an infant who is lethargic or has projectile vomiting. These words carry heavy emotional weight, but clinically they are noise. Relying on panicked adjectives masks the true biological signals. A baby vomiting from a surgical obstruction looks identical to a baby vomiting from sudden, catastrophic adrenal failure. Using subjective histories to guide your workup is a direct path to a misdiagnosis. Instead, we must look for objective diagnostic tipping points. These are the specific biochemical and physiological metrics that separate benign issues from lethal emergencies. We are going to decode 3 of these critical divides: electrolytes, ammonia, and bone age. Mastering pediatric emergencies requires training your mind to filter out the subjective clinical noise and actively hunt for these objective chemical divides. Let's apply this to a 3-week-old infant presenting with severe recurrent vomiting. The top 2 suspects on your differential are pyloric stenosis and congenital adrenal hyperplasia, or CAH. Pyloric stenosis is a mechanical block. The infant vomits gastric acid, losing hydrogen and chloride. This produces a highly specific lab profile, a hypochloremic, hypokalemic metabolic alkalosis. CAH, specifically 21-hydroxylase deficiency, is an endocrine failure. The lack of aldosterone means the kidneys dump sodium and hoard potassium and hydrogen. The resulting labs show hyponatremia, severe hyperkalemia, and a non-gap metabolic acidosis. So if you are handed a chart for a 3-week-old female with ambiguous genitalia, vomiting, high potassium, and a low pH, what is your immediate medical intervention? You must start aggressive fluid resuscitation and IV hydrocortisone immediately. The trap here is getting distracted by the viralized genitalia and calling a surgical consult, while the patient actually dies from a hyperkalemic cardiac arrest. In the vomiting neonate, ionic polarity, not the physical force of the vomiting, is the only reliable, life-saving signal. This flowchart illustrates the diagnostic pathway for a lethargic infant with hyperammonemia. When ammonia is elevated, calculating the anion gap is your immediate, mandatory fork in the road. A profound high anion gap metabolic acidosis points directly to an organic acidemia. If the acid-base status is normal or shows a respiratory alkalosis, the pathway leads down to a urea cycle defect. There is an important genetic exception to note here. Most inborn errors of metabolism are autosomal recessive. However, ornithine transcarbamylase, or OTC deficiency, breaks the rule. It is X-linked recessive and classically affects males. Once you isolate the pathway, the absolute ammonia level dictates your intervention timeline. Mild elevations keep you in the green zone for genetic profiling. Pushing above 200 micromoles per liter puts you in the yellow zone, requiring IV glucose and sodium benzoate. Crossing 500 micromoles per liter is a red zone emergency, demanding immediate hemodialysis. The anion gap secures your initial diagnosis, but the absolute ammonia number dictates the aggressiveness of your intervention. When evaluating early pubertal velocity, secondary sexual characteristics appearing before age 8 in females or 9 in males, you must follow a sequential workup. The mandatory first step is always an X-ray of the wrist to determine bone age. If the bone age is advanced beyond the chronological age, you must investigate the hypothalamic pituitary gonadal axis using a GnRH stimulation test. The patient's response gives you the exact location of the misfire. A high LH response means the brain is driving the process, indicating central precocious puberty. A low LH response means autonomous gonadal or adrenal drive, indicating peripheral precocious puberty. This distinction prevents severe execution errors. Take McCune-Albright syndrome, which causes a peripheral hormone excess. Treating a peripheral condition with a central pathway drug like leuprolide is mechanically useless. Identifying the exact anatomical point of axis failure is mandatory before prescribing targeted endocrine therapy. Your ultimate execution test in pediatric endocrinology is responding to an abnormal newborn screen for congenital hypothyroidism. Thyroid hormone is the primary architect of brain myelination in the first weeks of life. Every day the brain goes without it, the therapeutic window for normal cognitive development closes a little further. The clinical mandate is absolute. You never delay levothyroxine therapy while waiting for confirmatory labs. Lost IQ points cannot be regenerated. To consolidate our mental model, let's review the 3 objective tipping points. First, for the vomiting neonate, use potassium and pH to distinguish CAH from pyloric stenosis. Second, for hyperammonemia, use the anion gap to separate organic acidemias from urea cycle defects. And third, for precocious puberty, use bone age and LH levels to separate central from peripheral drivers. Abandon the subjective traps, trust the objective algorithms, and always prioritize protecting the developing brain.